And so I think the recording started, so we can get started, Dan.
Sure. Yeah. So welcome, everybody. This is the Greater Baltimore Regional Integrated Crisis System, or GBRICS Partnership Orientation. It'll be a pretty brief, high-level overview of the history and components of GBRICS and our goals for the project and for the region as a result of the efforts of this project. This is intended to be high level, so apologies if you've been through a GBRICS orientation or a briefing before, but this is really designed for folks who are not very familiar with the initiative, so that we can all have a shared level of context for what we're hoping to achieve with GBRICS. And so to start, GBRICS is has come into being thanks to the Regional Partnership Catalyst Grant Program at the HSCRC, the Health Services Cost Review Commission. HSCRC is an agency that oversees hospital budgets, and Maryland, as you may know, has a very innovative and unique hospital financing system called the Total Cost of Care system. And that allows HSCRC as the administrator for hospital funding some flexibility for what is done with hospital funds. And so there's been a series of these Catalyst grants, and this is the latest iteration. And the idea is to use hospital funds to invest in innovative initiatives with the hope of reducing long-term hospital costs in the long run. And so in January 30th of 2020, the HSCRC released an RFP for a couple different kinds of regional partnership Catalyst grants, but one of them was focused on the Crisis Now model and augmenting and scaling up behavioral health, mental health and substance use disorder crisis response services. Crisis Now is a nationally recognized model of care, and HSCRC identified that model as the most promising framework for a crisis response system. Some other key aspects of the grant was that partnership and collaboration was highly prioritized. Planning for sustainability after the 5-year grant term was very important. And as a result, BHSB and its partners have built collaboration and partnership and planning for what happens when the grant ends and how these services can be made sustainable, really baked in to GBRICS. We submitted the proposal in July of 2020 and received the award shortly thereafter. And the project started formally in January of 2021. It's really based foundationally on the Crisis Now model. You see this infographic here. This is what we are aspiring towards. And we're not that far off from this in the Baltimore region in Maryland, but we're not all the way there yet either. So this is what an ideal crisis system would look like. The person in crisis, the person in need, would have some place to call to get help. When recalling that crisis line would be able to dispatch mobile crisis teams into the community to meet people where they're at and intervene and support them. And then there would be somewhere to go other than hospital or jail where people could stabilize. And these are crisis stabilization centers. And there'd be ready access to wraparound services after the crisis incident had been resolved. And the goal of this at the end of the day is to decrease the use of jail, emergency departments, and inpatient hospitalization. We know that most people who are experiencing a serious mental health or substance use urgent need are best served in the community in a less restrictive setting. It's not true for every situation, but to the extent that we can provide care in the community with less disruption to people's lives, I think the better. And the goal is also for 911 and law enforcement to refer into this crisis system so that 911 operators and law enforcement officers are able to attend to other needs that that are more appropriate for their skill sets than mental health interventions. The system we have today, like I said, has a lot of these components, but the scale that we have is not up to, does not provide enough services to meet the need, particularly in the Baltimore region. And these different services are not coordinated to the extent that it could be to best serve the residents of the region. So that's really what GBRICS is aiming to do, is to build out a crisis response system that really can provide these services dependably and integrate them into the broader behavioral health and healthcare systems, so that people can get the care they need when and where they need it. So like I said, we were awarded the grant, which is very exciting. Started this year. It's a 5-year-long grant worth $45 million. And those funds will be invested in infrastructure and services to build on the strengths of the system that we have today, so we can have a more coordinated, integrated system that can meet the needs of the region we're serving. That region is Baltimore City, Baltimore County, Howard County, and Carroll County. You see it on the map there. And the award in the program was developed in collaboration with all the hospitals across that region, which are 17 different hospitals, 5 hospital systems, and 2 independent hospitals. And that is just an unprecedented level of coordination between hospitals. And then coordinating between those hospitals and the local behavioral health authorities across each region, of which BHSB, where I work, is the Baltimore City Behavioral Health Authority. But then there are local governmental agencies in each of the other counties. Coordinating across those with all the hospitals and with all the partners has really been a huge lift in the fact that we've reached this point where there is buy-in and support across all these different entities is really something we're very proud of and excited about. At the end of the day, we had 38 organizations sign on as supporters for the proposal, including, and we had 25 letters of support from elected officials as well. So what are we going to do? At this stage, I'm going to pass it to Shauna to walk us through the specific components of GBRICS and how we hope to augment and strengthen the current system.
Great, thanks, Dan. And can you all see me? Yes. Okay. My recording is just showing Dan and not me. So hopefully I'm being recorded. I did see a message in a question in the chat, which I'll just say quickly about why Anne Arundel and Harford counties weren't included. I think it had more to do with the hospital systems that were involved. That's my understanding. Of course, this all predates me and Dan as well, the development of the program, but maybe at the end, if Dan has a more detailed explanation, he can jump in. But I will tell you a little bit about the components of the program. So, and we'll go into a little bit more detail about those as well. So a major component is the comprehensive call center, which is a regional integrated hotline. And what's really different about this is the new software that we're going to be using that'll allow for real-time bed registry. So there won't be any more calling around to find an open bed. And also the ability to schedule appointments right from that system for outpatient appointments, and also to dispatch mobile crisis teams and be able to track where those teams are, how long they've been out on the call, those kind of important things. And the data dashboard, which we'll be able to share that information with the public, which I think will be really important as well. Mobile crisis teams, we're really creating standards for those for the region. Right now, there aren't standards for mobile crisis teams, and we'll be greatly expanding those. Again, as I mentioned, we'll have open access scheduling, so we'll be able to offer same-day appointments. And when someone calls for that follow-up to their crisis call, we'll be able to offer them an appointment for that day or the next day. Dan is going to talk more about the community engagement and outreach, but this is really important part of our program to support the culture change and to really encourage people to use the new call center as an alternative to calling 911 or going to the emergency department. So how do we create that culture change? And that's what our community engagement team is going to be working on. And really having that multi-stakeholder oversight so that we're going to have a lot of accountability. We'll be able to see like the things that we are not funding through GBRICS, like crisis beds, through the data that we'll be able to collect and share publicly. We'll be able to see what that need is. So I think that'll be really important. Next slide. So these are the vision and the guiding principles that have been adopted by the GBRICS Council and really lays out what our vision is, which is establish behavioral health crisis care as a fundamental element of emergency response and suicide prevention in the Baltimore region. And you can see the other things that are important to us, the equity, that we're going to promote equity through policy and systems change, align with the Crisis Now model, which you can look up if you're interested. There's also a link on the GBRICS webpage, but that was something that was required as part of our project through the funders. Timely access is important. Minimizing police involvement with the understanding that we will still be able to partner with police for the more complex situations that we would need to respond to, but to also just expand that ability of behavioral health providers through mobile crisis teams, behavioral health providers and peers to respond. We want to take a standard approach and involve stakeholders and communities, and again, have that data to improve outcomes. And also we want to be clear the return of investment that we're providing so that we can have a sustainable system. And next slide. So as I mentioned, the call center is pretty key to this, and we're going to be using new software for this, which we're in the process of purchasing, to have that real-time coordination, the data dashboard that I mentioned, being able to dispatch mobile crisis teams, and also allow that flexibility for each jurisdiction to also follow their own protocols. We will be the 988 number for the region, if people are familiar with 988, which is the new 3-digit number for the National Suicide Prevention Hotline, as well as eventually we're planning to have 911 diversion. So calls that are really behavioral health in nature can be diverted to our call center. There's a couple of pilots going on around that right now. Yeah, Dan, you can go to the next slide. So the other component is mobile crisis teams. And really, there are already great existing mobile crisis teams in the region, but we're going to be greatly expanding mobile crisis teams by 230%. We will be having specialized teams for children and youth and other populations. And really, because we have that larger area, we will be able to have that economies of scale that will allow us to have specialized teams. And we'll be dispatching through the call center. Next slide. And the final component that I'm working on is the open access. So we want to be able to, like I said, to be able to schedule through the call center. This has been done elsewhere. And we're gonna, in order to make sure those appointments are available, we will be engaging with a consultant who will be working with clinics that on a voluntary basis will come forward. They will be compensated for their time with some seed funding, and we will be increasing the number of same-day slots so that we can link those to the call center and give people an opportunity to follow up on their care after they call us. And I do see a couple questions in the chat, and I'm thinking maybe we want to save those to the end at this point.
Sure.
Okay, I think it's back to you, Dan.
Yeah. Thanks, Shauna. Yeah. So like Shauna said, GBRICS gonna have a state-of-the-art comprehensive call center to serve the whole region. We're going to dramatically expand mobile crisis teams, the number of teams out on the streets, and we're going to increase the availability of same day or next day outpatient services for mental health and substance use treatment for people. And that's all well and good, but none of that's going to work if the culture of our communities is still to call 911 or go to the emergency room whenever there is a need. We need to really invest in partnerships in the community and in building trust and demonstrating that this alternative system that we're building of calling 988 and accessing mobile crisis teams as opposed to calling 911 and having an ambulance or a police, a law enforcement officer come out, that this alternative system can be depended on. And so in order to do that, we have a robust community engagement and consumer engagement strategy that's built into the GBRICS initiative. To support that, we have kind of a few different components. One is we have a dedicated community engagement coordinator that is joining our GBRICS team. And they're starting very soon. So that's very exciting. And they'll be devoted to community engagement full time, to going out to neighborhood associations and community groups to share information about GBRICS and get information about what sorts of needs those communities are seeing and what kind of concerns those communities have. In addition to that staff person, we have a community engagement committee that is dedicated to coordinating and strategizing around what kind of community engagement we want to do. And then we've also hired a communications and marketing firm to help us to do market research and conduct a paid media campaign for like a public awareness and public education campaign to support not only GBRICS, but also calling 988 and generally destigmatizing reaching out for help for mental health and substance use needs. We really think that this consumer engagement can help integrate crisis response services into the broader continuum of the behavioral health system and the healthcare system, and want to see this as a key component that people feel comfortable using. So that consumer and community engagement is really foundational to those other services that Shauna walked us through, so that folks use them. Our accountability, we have a council, the GBRICS Council, and that is made up of 21 seats, some hospitals, some local government and state government, and many community-based organizations and other stakeholders. This council provides strategic guidance and kind of oversight for the GBRICS initiative. BHSB's role is really more just like day-to-day project management, but we know that this is a huge undertaking, like with these 4 different jurisdictions and all these hospitals and all these different systems. So we know that we can't do this all on our own by any means. So we are really committed to getting community input and developing community partnerships so that we can tap the expertise, both like professional expertise and lived expertise of the residents of this region. And so in addition to the council and the community engagement committee that I mentioned, Shauna has a number of work groups, like one work group devoted to each of the components that she went through, the call center work group, mobile crisis team work group, and open access work group. I think between all of those work groups and committees, like we have like 150 different people who are serving in one capacity or another to help provide input and strategic direction for how GBRICS is implemented. In addition to that, we're routinely meeting with each LBHA as well as BHA at the state, the Behavioral Health Administration, as well. GBRICS is implementing its reforms and making its investments. There's a number of other crisis service related and broader mental health and substance use related initiatives that are going on across the state. And so we want to make sure that we're also coordinating with those efforts. Here's that accountability structure kind of visualized. You see like the GBRICS Council at the top, the two committees that are standing committees. I don't know that I mentioned Policy and Advocacy yet. Policy and Advocacy Committee is really devoted to what sorts of policy changes are needed to ensure GBRICS is successful and sustained in the long run. I think the biggest thing we're looking at right now in that regard is establishing dedicated funding for the crisis response continuum through a 988 user fee that would be levied similar to how 911 is funded today. 911, there's a small fee on every cell phone and landline phone line, and that fee goes into a fund, and that supports a big chunk of the EMS and 911 system. We want to see the state of Maryland create a 988 fee that can support crisis services in a similar way. And a number of states are looking at that right now, and we hope that Maryland will follow their lead. 3 states, I think, have established a robust fee already. So that's some of the work that the Policy and Advocacy Committee is looking at. And then BHSB is a regional administrative manager, handles the day-to-day. And then we have the different work groups like Shauna staffs, as well as RFP proposal review committees. All of our funding is being allocated through competitive RFPs. And so we have external partners who serve on those review committees. We've only made one choice so far. We hired the communications and marketing firm, but as the call center and mobile crisis team and open access supports get stood up, there'll be more and more RFPs and RFP review processes. And then there's this host of community stakeholders, many, all of you here on this call, as well as literally hundreds of other folks who are on our mailing lists and helping us in one way or another. A really important thing to bear in mind with GBRICS is the implementation timeline. It's a 5-year program, and this is a really complex multi-stakeholder effort. And so we're really grateful to have 5 years to implement this. Year 1, that we're halfway through right now, is really our build year. We're establishing all of our committees, receiving all the input we need, and providing all the updates that we can to key partners, and planning for implementing things starting next year. Next year is when you'll see the call center go live, when the mobile crisis team expansion RFP will be issued, when we'll acquire the consultant to work with existing community providers so that they can offer open access appointments, and when our communications and marketing campaign will launch, and when our community engagement work will really kick into high gear. So that's all next year. This year, we hope to establish the standards for mobile crisis teams that will inform the RFP, and adopt our policy agenda, which will inform our advocacy campaigns over the next few years, and to acquire the back-end software and infrastructure necessary for our call center to make appointments and referrals in real time to people who are calling, and help to dispatch and monitor mobile crisis team activity. That implementation will continue in year 3. Then at year 4 and 5 is when we really hope to be 100% operational, and we'll be able to demonstrate the impact and return on investment that this investment will hopefully achieve in the form of improved care for people experiencing urgent mental health and substance use needs, as well as a reduction in ER use for behavioral health, and a reduction in law enforcement interaction and incarceration. So that's our goal. And I think those 5 years will be here before you know it. And so we are today already planning for sustainability beyond that 5-year grant window. We are thankful for the funding that HSCRC is providing for this initiative, and hope to demonstrate that it is a sound investment. But we know that we need policy change and support from other aspects of the public behavioral health system if we're going to sustain this beyond that window. So our strategy there, one, is to provide consistency, standardization, and accountability for these services by developing standards for the mobile crisis teams and protocols for the call center, and generating the data that we hope to generate through the call center around timeliness of response, success, like what the outcome of the response was. We hope to show that these services are dependable and should be funded as such. We also know that standardization is really important for health insurance reimbursement, both Medicaid and private coverage, which we see as a really important long-term component to a sustained and robust crisis service continuum. And so that's one real big thrust of our sustainability strategy. The other is advocacy and policy change. Like I mentioned, we see 988 and specifically the establishment of a dedicated 988 fund as critical to the long-term sustainability of a robust crisis response system, not just for GBRICS, but across the state. We also think coverage by Medicaid and private insurers is critical. And we hope that the data that we're collecting can be used to seek those supports, as well as to identify what other needs there may be in the system, and help to make the case for public investment to address those gaps. So that is GBRICS in a nutshell. We could go into a lot more detail, but we'll stop there and open it up for questions. And Shauna, I don't have you been tracking? Do you want to help kind of lead through what was dropped in the chat?
Sure. So let's go back to the. So Dan, I don't know if you had anything to add about Anne Arundel County or Harford County. That was my understanding, is that we were the hospitals in that region weren't part of it. I don't know if there was another reason.
I think that's my understanding as well. We were, BHSB was willing to work with anybody and just kind of made an open invitation, and those counties didn't volunteer to work with us, in part because of the hospitals that are there. I think there are some hospital systems represented in those counties that weren't represented in the other four counties we did end up working with. But just the 4 counties we're working in are almost 2 million people and 30% of the state's population. So that's plenty, and so we're happy to have this focus that we have.
And that goes really to just to answer the last question that came in about expanding to the rest of the state. I know that the Behavioral Health Administration of the state of Maryland is looking at GBRICS as a pilot project, as well as the other regional partnerships. There's one in PG County and then one on the Eastern Shore. So they are looking at all of us as pilot projects, and I'm sure they'll implement the parts that they like. Dan, there's a question from Kirsten Downs about, are there plans to inform the courts or judges or other criminal justice stakeholders real-time bed information and monitor referrals would make the difference in reducing pre-trial incarceration? I can just speak for Baltimore City and not the rest of the region, but I know that we are, BHSB has our own diversion programs that we're in close communication with, but I don't know, Dan, if you have any thoughts about how this would work in the rest of the region.
I think we'd love to see strong coordination and integration with with those types of services. I don't have any additional detail on the other jurisdictions, but the vision for the call center and the back-end infrastructure is that it would be able to divert people to community resources and services, kind of like with a no wrong door approach. So wouldn't have to come through a mobile crisis team. Like it would be like anybody that could call would hopefully be able to access that information and get prompt referrals to services.
Thanks, Dan. And then Ari asked a question, does police response refer to all police or patrol police? He's curious about jurisdictions that have police officers specifically trained in crisis response. So the idea behind GBRICS, we won't be kind of replacing the system that's already in place. That system will continue in each of the jurisdictions. What we will be doing is offering mobile crisis teams for those, I guess you would say, lower acuity crises that don't really require law enforcement response. And we'll be really beefing up that part of the system so that, plenty of those opportunities will be available. And through the call center, we're hoping to be able to triage those calls. So I know there are trained police officers. I know in a lot of counties already, sometimes they will also, there's close coordination with mobile crisis teams to send out a mobile crisis team if a police officer isn't needed so they can get back doing other things. The call center location isn't determined yet. There's a question about where the call center will be located. So we will be issuing an RFP next year for the operator of the call center. We have determined the software that's being used, but we have not determined who is going to be operating the call center. So that's an open RFP. So once we have that call center operator, they will be determining where the call center will be located. Let's see, next question. The relationship of the call center to the suicide prevention hotline would still be available, or will this replace it? So my understanding of the way the National Suicide Prevention Hotline works and how 988 works is that when someone calls that National Suicide Prevention Hotline, it's transferred, that call is transferred ideally to a local hotline, and if not, there are statewide and national backup systems so that the call is always answered. But GBRICS will replace the existing hotlines, and we will be the 988 number for the region. And as far as text goes, there will be still text available the way there is through the National Suicide Prevention Hotline. Whether GBRICS is the one operating that or not, that's something we haven't gotten to yet, but we will be figuring that out. And Dan, do you want to talk about how community organizations can get involved in outreach?
Sure, yeah, so we are looking for any and all partners to help support outreach and promotional efforts. We want to be a little careful because these services aren't available yet. And so I think we're gonna sort of time our big push or our launch for doing a lot of outreach and promotional awareness raising with when 988 goes live in July and when the new GBRICS call center is fully operational. So that's still like a year away, but we want to connect with any and all organizations who are interested in helping to support this effort. And you can contact me. My email address is there on the screen, daniel.rabbit with 2 T's at bhsbaltimore.org. And my cell phone number is up there too. And I would love to chat more about like kind of what level of involvement or what like kind of what your interests are and how we can potentially partner some things we're doing between now and July. You know, July's a year away. We're definitely doing lots of engagement activities in the meantime too. We're going to create a survey to obtain, you know, just some kind of basic perspectives on what sorts of hopes and concerns people have about the crisis response system and the broader behavioral health system. We're also hosting a series of roundtables with community partners. And so that's another thing that I'd be interested in potentially partnering with different organizations on. You know, we want to make sure that these roundtables you know, include participants that represent the full diversity, both geographic diversity as well as kind of like population and identity diversity across the region. So that's another way to potentially plug in. And then we also have our community engagement committee, which has, you know, over 50 organizations represented already, but we're always open for more. And so if an organization or a person is interested in really committing to helping us to strategize about how to plan these events and how to get out in the community, you know, we'd be open to that too. So I'm not sure who asked Shauna about like how to get involved, but they can reach out to me directly by email, or if they're on the call now and want to share sort of what their interests are, or if they have other questions, that'd be fine too.
Great. I'll just mention that people can also reach out to me if you're interested in the mobile crisis team work group, the call center work group, or we're just getting ready to launch our open access work group, and we'll be having a data and outcomes work group, and we really need help with those if anyone's has an interest in that. And just so, I want to say Denise has her hand raised and has been waiting patiently.
Yeah, I just was curious if there is any concern that there will be kind of a bottleneck at the crisis facilities part of the continuum, because if we're able to better direct these calls, there's still a crisis bed shortage, particularly with the adolescent population. And I just wondered, I know that Shauna, you mentioned how this will be helpful in tracking that data, but before we get to that point, once the program starts, if we have nowhere to put people, I just wondered if a work group was addressing that, or if you could elaborate on that a little bit.
Yeah, so really, I know $45 million sounds like a lot, but we didn't have enough really to expand crisis beds with that project and do everything else that we felt was important. So we're really reliant on the state to do that. And from my understanding, the state is really looking at expanding 23-hour observation beds for adults, which I know doesn't answer your question about child and adolescent. So really, I think that advocacy, we are a part of the work groups with the state. So we're part of that. I know just in general, the state is going to be using some COVID relief funds to really ramp up crisis system for children through the school system and elsewhere. And when that fund, if those funds run out, we're hoping to pick that up because we will be launching at that point. But again, that you're right, it doesn't include crisis beds, which I know is really a huge issue. Unfortunately, it's just beyond our scope. But we are part of those efforts, and then we will have the bed registry, so anything that does become available will become part of our system. And I did want to refer people to the webpage that Amy posted for more information. And Mr. Logan asked again about the work groups and how do you get involved. So just email me or Dan, we can add you to the mailing list for that, or we'll probably have a conversation with you about that first. But the work groups meet monthly with sometimes some work in between, some subgroup work in between. Let's see. And so the open access work group really is going to be with people who want to expand same-day access to behavioral health appointments. So either if you have experience in doing that, or you're a clinic, that has experience, or if you have a lot of ideas of where the gaps are, that's one thing we want to really figure out, where in the region there are gaps, or is there a bigger gap with children or with adults, and set that up. So we are just beginning to think about that. So that's all I know so far. I don't know when we're going to meet or anything. We're just starting to get that launched. And that's all I'm seeing in the chat. Thank you for the couple of people who said that they want to get involved. We appreciate that. And other questions, we still have 15 minutes. So.
And you can take yourself off mute if you have a question, or if people feel like they got it under wraps, then we can give you 15 minutes back as well.
Yeah, I was gonna say, I appreciate the overview. I feel like I definitely now understand, or can, I think engage a little bit more. I've seen a lot of communications on email and things like that, but I definitely am going to send you all an email, and hopefully we can follow up and find the time to see if No Boundaries is also aligned with the mission. So I have to jump, but again, I appreciate it, and I look forward to talking with you all. And hey, Mrs. Slater, I see you over there.
Great, thank you so much for joining. We really appreciate No Boundaries interest in this. It's really important.
No problem.
Thanks so much. And actually, I see Mr. Harrington has his hand raised.
Yes, I just wanted to say thank you so much. This has been a wonderful presentation. I represent Market Center and a coalition of different partners working in downtown Baltimore to kind of support behavioral health services for the community members that are there. And one of the things that we definitely saw as community was there's a lot of overdue burden on emergency rooms and police to kind of triage behavioral health services. And sometimes it's not the best result for community members. So we've been thinking about that and working on that. And so we're so excited about the partnership that GBRICS is doing and kind of bringing this policy and systems level change. And we're kind of more on the ground, grassroots, right? So we're going to be so excited to educate business owners, community members about 988 and other resources to call. And we do believe Market Center, since it's at the heart of Baltimore and folks come from all the regions, just by working in Market Center, not only can we improve our community, but hopefully the whole region. So we're just super excited. So any support we can offer, or if you can be a geographic area, you can test out how the call center is going, or mobile response teams, we're there to support you.
Great, thank you so much.
Yeah, thank you.
So other questions about GBRICS so far? Any other closing thoughts, Dan?
We just really appreciate your time. We've been, humbled by how much interest that has been shown in this initiative, and we're really excited to keep moving ahead with the planning and implementation. And I was really excited to partner with everybody to help improve the care that people receive, and hopefully improve the system along the way.
Great. Thanks, everybody. And you have our email address from the presentation. It's also, I think maybe Dan's email address is on the website. Also, you can reach him that way, and he'll connect you to me if needed. But all right, thank you so much. And I look forward to working with some of you. All right, take care.
Hi, everyone.
Bye.